afternoon, everyone. I'm very pleased to welcome you to the session 4 of the ETEL sessions this festival, for the Radical Health Festival on the EHDS. So the yellow button is Innovating for Everyday Life with Patient Access. I'm Shane Fitch, a member of the ETEL board, and also we have our own digital health ecosystem, so I'm joining you not just as a representative of citizens and their right to access to their personal health history, but also as an implementer. So I have a little bit of a double hat here, and hopefully that proves interesting for us all. Anyway, I'd like to welcome our panel, and a quick intro, if you don't mind, Carla, Carme, Stefano, and Michael, just so everybody gets a feel of who you are today.
Hi, my name is Carla Álvarez. I'm the head of the public funding programs at Fundació TIC Salut Social, which is an entity within the Ministry of Health in Catalonia, and we work to promote the digitalization process within the public health sector.
Thank you.
Hi, good morning. I'm Karma Pratapadua, and I'm responsible of the health area in TIC Salut, also with Carla. We are working in the digital transformation projects and so on. So thank you for inviting me.
Hi, good afternoon. I am Stefano Darmiani. I'm the Chief Digital Officer and head of the Bioengineering Department of Monastery Foundation, that is a public research hospital. We have long experience on the application development of standards in the healthcare settings, specifically for cardiology. Thank you.
And I'm Mikael Rinetmäki, and I'll top Shane's 2 hats with my 3 hats. So my main job is within Finnish Innovation Fund Sitra, where we coordinate EHDS implementation for secondary use in several projects. And I'm also a healthcare entrepreneur and founder of Sensotrend, a diabetes startup. And in this session, I guess I'm mostly presented as a volunteer of HL7 Finland that advocates for use of health data standards. So
Thank you very much, Michael. So when we look now at the EHDS and we're thinking about patients' rights, citizens' rights, from the Articles 3 to 10, we need to recognize the right of people to access their electronic personal health data and to be able to download data from an EHR system or a validated data sharing platform, insert and rectify personal health information in an EHR system, and transmit their health data to healthcare providers or other third parties of their choice. So this is giving much more scope to people to be in charge of their health, and of course is, as we've seen today, giving rise to multiple ways that we have to apply our systems to transform and be able to respond to this right. So I'd like to ask firstly, Stefano, can you tell us a little bit about your own initiative in this line? Thanks.
Thank you. So that's me. The share that contains the yellow button concept is actually something that has 3 pillars. Some of you perhaps joining the first session this morning already got some information from Katrin Kronaki. She is the leader of the Share project and the inventor of this yellow button, perhaps not the color. And the concept stands in an easy way for the patient to access their own information. So this is the patient empowerment part. But we have also something that is planned to support the development of the European Electronic Health Record Exchange format, a very long name for something that is actually complex, that will follow the current definition of the standard formats that is centered on HL7 FHIR for the next few years, because we are planning to maintain the standards according to the evolution of the ITs, but also of the medical science, because we need to remember that IT is just in support of medical science. If we are connecting medical science evolution with IT, we need to manage this somehow, and the Asia consortium managed by Mark Lang is something that is included as a starting point in XShare. And then we have some kind of support for us, hospital, that need to buy something that is consistent. So the certification of a so-called XShare label, that is an industry label, needs to support somehow the certification of one single EHR solution provider, laboratory provider, something that supports anyway the healthcare professionals in the generation, the correct, proper generation of the standards of the HRXF. And this for some so-called data categories. And the data categories start from something that is really consolidated right now, that is the patient summary, up to the laboratories and discharge report, including also the secondary usage for EHDS. That is this IPS plus R, that is an extension of the patient summary specifically for research. So we know that for research, the secondary usage is included in EHDS, but how to support research, just extending also a little bit. The common data that we're using for patient summary is included there. Care plans, we have Michael, the next speaker, that will talk about this and the next session. We have 3 different methodologies or implementation for the XShare or yellow button. That is, okay, I want to download the file. And that is not just the regular file that the patient receives somehow from one EHR system, but is the standard file according to the new regulation. And we have also the coverage of the data exchange between the patient and the healthcare professional. That is the one-time share. I want to give that file, that content to just one person, to just one healthcare provider, and just once, because I am visited by that professional just once. So I don't want to keep it updated for the next evolution, for example, of patient summary. But we have also connected option. The linked option is something that permanently, of course, up to the opt-out of the patient, connects the patient evolution with the healthcare professional, healthcare provider, I don't know, general practitioner. Disconnect physically, more or less, 2 different repositories, one that is populated by some stressed healthcare professional that sometimes needs to deal with some cumbersome EHR system, and they don't really know what is going on. Using something that is already in the availability of the healthcare professional and patient, for example, personal health records, but also patient portals, the future e-wallets, and something else that will appear perhaps in the next few years. With our MarineX Arca, that is our test patients. So we are connecting 2 different entities with the format. This is the technological implementation. Sorry for the technicalities, but this is just a bunch of open source components. This is to support public implementers, just like us, and the industry at the same level, providing some components that can connect the internals principles applied for the usage and sharing of the standard data with other external parties, but also with the patients. We have some implementation. We will see briefly what might be an implementation. We have connection with also European and other projects. European level, My Health at EU is the most qualified reference for this level, but other project that is going on in the next future. Just one word of my experience as an implementer, as the first implementer of this in the XShare project. We are a public hospital, public health provider, but we are also a research hospital. So we are dealing with both parts of healthcare and research, because all of our physicians and surgeons are researchers. But we have also a strong IT department with a long history in EHR system development, so that's why we are used many times in many projects as early adopters, because they can experiment with us what is going on. And we are connected, we are sharing the hospital on fire network with 120 hospitals. So we somehow broke also our position with the general levels of other hospitals. Starting from a common perspective, we have an EHR system. Okay, many hospitals have an EHR system, but our EHR system has some experience on it because it has 25 years of experience in development of many releases to adopt the contents and the representation of the contents and the data collection and the structured data collection and the unstructured data collection in the process of healthcare. And we are compliant with some standards. All the standards, CDA is an older standard? We don't know. Currently, many countries adopt CDA as a national standard, also in Italy, but also future standards just like FIRE, R4, R5, R6, and of course other consolidated standards just like DICOM. So from this bunch, in this example, in our first implementation, from this bunch of information that are coming from the EHR system or EMR system, as you want to call it, as classified by HIMSS, but I would continue to call it EHR because we are conveying information also coming from GPs, coming from other hospitals, coming from other laboratories. So we are using an EMR system, but with an EHR content. The EHR produced automatically and validated and supervised by the physician a discharge summary, discharge report. This discharge report is a CDA currently, and is a PDF also. So we have a PDF that is digitally signed because national regulation requires so, that has a CDA that contains the PDF format. So we have a structured format that contains an unstructured format. The patient has a patient portal that can be accessed using the national infrastructure that is compliant with the EIDAS, and sees this, see the list of reports. This is, of course, a synthetic or fake patient. See the report that you can have there on the right-hand side of the slide, position the share button. This is our easiest way, defined also by our patient and focus group, how to access directly without adding any complexity to the graphical user interface and download the structure format that is this one. So this is a direct and simple implementation that every hospital more or less can have in their own, let me say, IT service provision. But we consider also the effects of the national regulation. We managed to somehow reverse not the national regulation but the implementation, because luckily the national regulation evolved in the last 2-3 years, reverting the model that now includes a PDF that is digitally signed that contains as an attachment the structure format. So we generate now the PDF, we digitally sign it with the digital signature of the discharged physician, and the PDF contains the structure of the hospital discharge report. The structure means the structure file, so the HRXF format. This is something that might be also used, and we are testing this in other environments, as a source, talking about the PDF format that doesn't have the structure on it, to extract or generate the structure part, so the other way around. So this is a continuous exchange of information according to the availability of data that is coming from the patient or is coming from an external laboratory or another hospital that is not really connected with us, from another region, because in Italy we have 21 regions and 21 different healthcare systems, healthcare services with different regulation. But at least we have one potential application, we talked about this also this morning many times, that is really promising because we are testing it, that can generate the final format easily. Easily means, doesn't mean reliable, because this is something that needs to be tested, and this is the main topic for the testing of AI system. So these are different parts, different so-called resources of HL7 that can contain observation, that is body temperature of a patient, or the glycemia acquired at home or through a medical device, to the procedure, to a medical condition that might be chronic or acute. So I would like to thank you, and perhaps I need to give back this to you.
Thank you, Stefano.
Carmen and I will be presenting the yellow button in implementation in Catalonia, and then we'll make a short introduction about the process of the industrial label. So, well, Catalonia has been driving a digital transformation of the health sector for over 40 years. We have been addressing this last year 3 main key challenges, which are ensuring the continuity of quality of healthcare, which means that the data of the citizens is available to those professionals that treat the patient, and also to those who generate knowledge for the benefit for everyone. As well, we want to ensure that we enable access to personal data across the public and the private sectors. And then we want to empower the citizens to enable the data ownership. So just for you to understand the context of Catalonia, we have a very fragmented healthcare system, and we have 2 sectors. The public ones, which is characterized because we have a single data repository that gathers all data from public hospitals and public primary care. And then we have the private sectors, where we have independent systems. Each one has their own personal health records, electronic health records, and each center decides what data collects and retains. So this is, as a starting point, leads us to the Blue Button projects, which is the starting point for Catalonia. In 2022, we implemented in La Meva Salut, which is the personal health record application, a tool that allowed the citizens to retrieve the IPS in XML format. So then within the XShare project, we kept working on improving what we did in La Meva Salut, and then we started working with the private healthcare sector. The way we did it, we started working with 2 private hospitals, and then we worked to the way that they can retrieve the IPS in FHIR now. So the current situation is that we have in La Meva Salut currently the downloading of the IPS in a real environment in CDA. We have ready the download of the IPS in FHIR that will be in real time in about a month. And then we have the available to download the discharge report and the e-prescription in PDF format. And then in the private sector, we can download the IPS directly from the PHR from 2 private hospitals in FHIR. And we are working with more hospitals to implement this functionality in the future. So just want to say that in the last EIT Connectathon, one of these 2 private hospitals was awarded with the silver label. And Karma will give you more details about how this process of the label has been done here. Thank you very much.
Thank you, Carla. So, as Stefano mentioned before, we contribute in the XShare project to build this XShare industry label that has been built to support companies in the adoption or the implementation of the European, to be prepared to the European health data space and the compliance with the European electronic health record exchange format requirements. So in that process, we contribute with different stakeholders in the project, and I think it's really important for companies to get ready for that European health data space. So we built this share industrial label in 3 different progressive levels, to make the depends to the maturity of the company and how it's which capacity has to integrate the yellow button. In that case, for instance, the bronze level, it's for defined by encourage the early adopters to implement this yellow button, and it's only a self-declaration of survey. There is no technical assessment or evidence check, but they can declare which are the requirements about that. The silver one is an upgrade of the bronze, which the company can provide more evidence, and in that case, we demonstrate and there is tested the consume and produce of this electron exchange format. In that case, the company can go in these plagathons that we went last year, and there the company used this Gazelle tool, that it's a platform tool created by IHE that can help to them to check and to see if this, for instance, the IPS or the laboratory report, etc., it's built properly. So this Gazelle tool can provide some results, and the company can improve the IPS until the process is completed. Obviously, in that plagathon, you have support by the IHE technicians that are there, and the last level is the gold one. That is the highest level of the maturity for the company, and it recognizes that the company is fully integrated and fully operate in the healthcare or national system. In that case, it's particular in Catalonia, we have already signed an agreement with the ICShare projects to start testing this gold label in our region in 2 private hospitals. Those hospitals will follow this flow chart where they will provide with some evidence. They will fill in an online request where they will send us the IPS and other evidence related to perform this assessment. And after getting all this evidence, we will do the assessment, and we will provide with some report and some with non-conformities or the things that we will do during performing this assessment. And finally, after if the processes succeed completely well, we will award with the gold label. So this process, I think, in the next months we will provide with you more results about this pilot stage, but I think there are a lot of more companies in our region that are interested to get or to be involved on that process. So finally, I think it's really important to say how or which actions we have undertaken to try to help and to promote implementation of this yellow button in our region. First, we have signed some strategic agreement with the 2 main private health associations to say and to explain the use case of this yellow button and how they can integrate it in their system. The second is it's really important to provide some grants or some incentive to companies to support in the adoption of this yellow button in their electronic health record. And finally, and it's not, and I think it's the most important part, is to provide some implementation guide or something to support and accompany and helping them to integrate these technical doubts that maybe they have. And finally, which are the benefits to implement this yellow button for companies? Obviously, to fulfill or to meet the requirements of the European health data space and legal and technical requirements. Also harmonize the exchange that the cross-border data exchange, and try to build this IPS properly implemented and fully integrated into the system. And finally, this seal of excellence, I think it's something that for the companies can show the maturity of compliance, with all of that. So and provides trustworthy at the end. So I think this is all from our side.
Thank you. This is from Love Air. We're giving our perspective on the yellow button. And I'd like to say again that what matters to us is our health and well-being, our air, and also our planet, as you know from the One Health plenary, whoever was attending. So, what is the level of interest and engagement that citizens actually have with all the different data sources that we can't always access, but should be available to us over time? Well, of course, we work in very many spheres, talking about our health or providing health data and information. Social media, we have the clinical environment, research environment, patient data, public health, private health, life sciences, and now also we have all the data that is accumulating through wearables, IoT, sensors, demographic data, which isn't always captured yet, unfortunately, geospatial data, and self-reported information, which isn't always given the importance that it can bring to understanding the patient condition. But what are the benefits that we're seeing ourselves in this new area of opportunity and the future of health? Well, we can see that we can integrate really an enormous amount of health information and data, which is totally fragmented in the majority of cases. We can also aggregate from IoT and have much more depth of knowledge about personal health, thanks to physiological information, as long as it's qualitative, of course. And we can participate much more actively in the future of research ourselves, because we have ownership of our own data, perhaps even with our own personal AI assistants, which aren't necessarily dependent on tech companies, but are more managed by ourselves. We can also incentivize sharing personal health information so that equitable access to care becomes much more readily available to more people in the world. And we know that this is incredibly important, especially for low middle income countries. And also we can be innovators in the future of personalised care. Why? Because we've already got much more depth and much more data, which is relevant for research pathways and clinical care pathways, which are going to change radically over time. So, citizen handholding is also a key job that we have to do from our organisations, our civic organisations. And in that respect, we need to be equal agents and equal stakeholders in this new environment of EHDS. We have to understand the benefit and make sure that we can clearly communicate them to people. We also have to ensure that there's a tracking history so that no misdemeanors, no misinterpretations, security is well managed, governance, and we can mitigate any misuse of data, should we wish to follow up. The digital health literacy support, well, it's relative to different populations, different segments, different individuals. It's not just age-related at all. It's really to do with the proficiency of people in understanding more about their responsibility of their own health. And we can further educate people. And we can offer guidelines in what the values and benefits these are to improve our health. And again, promote that equitable access, push that vehicle forward so that more people in the world can actually benefit from having their own health data in their possession. We also think that the endorsement of systems is beneficial with trusted compliant entities. So it's I think they've already gone, Carla and Carmen. But we do like the idea of having systems which have been recognised, public-private, private entities, SMEs, and so on, because that way we're going to feel more confidence in what we're using. We can also enter co-design. We think that's a great opportunity to give more user-friendly experiences in these new pathways. And we can have a proactive participation in care innovation, because we know really that most of care is handled in the virtual environment these days. So changing the models for lifestyle behavior and so on means that we can bring in new elements of social integration and communication which are beneficial to help people improve their adherence, which a word which I really dislike, but let's say their consistency in looking after their health. It gives civic organisations with a capacity to act in digital health an opportunity to be a real agent along with healthcare providers. And also we can facilitate this intersectorial collaboration, which we think is always been one of the major hurdles that we've had in healthcare. And now with the EHDS space, it gives an opportunity to overcome those barriers and actively engage sharing data from multiple and diverse stakeholders in much more seamless relations, which is what we've been looking for, I think, with cross-border care and so on. So thank you from my side. So what is the main barrier for citizens to actively use their health data today? Let's see. Sorry?
You can enter the code. It's on the top, 84386753.
Okay. That's quite a quick one, I think.
We are all brave here.
Yeah. So it's a communication issue, as usual.
It also might be that we have nothing to hide.
No.
We can share everything with AI and the world. It
Look,
doesn't apply to everybody. I'll start with this EHDS pain point. This is from the actual introductory text of EHDS, the cost estimates. So the European Union estimates that the cost of EHDS implementation includes about 100 million of public funding and then at least double that, if not 12 times that, from the industry. So the EU Commission expects that, hey, we'll pitch in some public money and then the industry just joins, gets excited and at least doubles our money, if not 10-folds or 12-folds it. Who believes that that's going to happen? No. Yeah, it's not in the actual EHDS preambles anymore, but it was when the EHDS proposal from the Commission.
The cost effectiveness evaluation.
But yes, it's not certain that this will happen, but we can make it happen. If we incentivize the industry, if we can show the benefits, hey, you do EHDS stuff, you do it early, it generates a better market for you. And at least in Finland, we see things pretty much like that. If we are able to move with EHDS far in advance, we can introduce the tools, we can have all of the EHRs here ready. And when the EHDS regulation actually mandates everybody to move, then we can prove that, hey, our systems have been used for years and they are reliable. Take our solutions into use. So there are some ways of making this interesting for the industry. Second pain point we were addressing in the Finnish Health Data Hackathon that I'm talking about was the patient access to their data. And that's also been one of the key areas in this session. And to me, when you talk about download, that's nowhere near enough. And Catherine Kronaki earlier today explained that the reason is the history in US where they had the blue button that enabled you to download your data. But that doesn't scale. If I download my data and then share it with somebody and something happens with my data, I get a new lab result, I get a new text from an appointment, I always need to download it and upload it again. And if I share it with a dozen different entities, then I need to download and do 12 uploads and download and do 12 uploads. That's not digitalization. Digitalization is about automation and removing the manual labor and human from the loop. So we need continuous real-time access to data, and we need to be able to give apps that real-time continuous access to the data. And that's why they did what they did in US as well. They started with the blue button, but now they're working with the smart app launch, and that is exactly with the apps and continuous access. Also, adding data to your own EHR. That's a fun, wonderful right to have, but nobody really knows what it means. Third pain point in the EHDS regulation, it covers something, but it doesn't cover everything. So we have been thinking with the industry, what are the points that are not in the EHDS? As Petra Wilson said early this morning, EHDS is, for many people, just the EHDS regulation. This is what's regulated from the EU level. But that's not true. EHDS is something more. It's when you actually have data sharing. It's not just what EU managed to mandate. Political decisions are hard, and perhaps they just were able to agree on download word, and perhaps they were able to agree on some things that they mandate, and not from the health point of view. So EHDS is actually regulation from the digital single market point of view. So what things are not there that we can still implement? So from industry point of view, we can do stuff that's not in the regulation, but we still think it's worthwhile. And these 3 pain points we addressed with the Finnish Health Data Hackathon that took place on Monday and Tuesday here as a side event to Radical Health Festival. We had 2 tracks. The first track was related to patient access. So we had plenty of implementations, tools, specifications, and people working around, okay, what do people do with their data? City of Helsinki joined the hackathon with their challenge. They have an Epic installation here, and they have their MyChart patient portal, but that's currently a standalone solution. So they are now considering, how about if we opened up the APIs the same way those APIs are open in US? What kind of apps would benefit from that data? How would people benefit from those apps? So they had a challenge there, and they awarded the winner with 2,500 euros and the second with 1,500 and the third place with 1,000. So there was some monetary prizes for there. But on the same sentence, I want to mention that all of this, all the rest of the hackathon was just based on voluntary work. And we have pretty good demos there, and if you look at the website, they are already there as videos, 11 entries altogether in that track. We also worked with digital identity wallets, so that's another EU regulation, but it's also a trend that's coming. So we can have digital identity wallets that help us prove who we are regardless of where we come from. That should be harmonized. But digital identity wallets can also act as a mechanism for you to store your essential patient information and share it. So we explored those mechanisms. Second track on the hackathon was about care plans and clinical reasoning. It was a bit less organized, but that was really addressing the third pain point I was explaining, what's not in EHDS. And care plans are not in the EHDS yet. And we did some really good progress there. We started a new FHIR implementation guide for care plans in Europe. And let's see, perhaps in the near future, we might have that sixth priority category in EHDS. The results are available on the hackathon website.
Beforehand, we need to acknowledge perhaps the new regulation, European regulation, that recognize the current format of implementation guide as the standard. And then we might ask to software developers and the industry, okay, this is a way to access your data, just like the left and right click of a mouse. You can access your data through this interface, physical or graphical interface. And if you want to allow your customer or your operators of your application, you can implement that button in this way. So this is also a graphical identity that is useful to support the diffusion and implementation for further development of the standards, because we are currently really at the early stage of the EHRXF, because we need way more. We need a specialist IPS. We need a lot of different other documents. We need the translation of the document into several European languages. So we need a lot of things. And the button is just perhaps the beginning. We'll say, okay, we need to create something common, something graphical, something that can be used to advertise all the patients or citizens that you can do, and you can apply your digital portability rights in that way. But you have also the potentiality to be in control, because with the download of the file might be easier. I give the file to her, and that's it. And so I know her, and of course I cannot update her every 5 minutes with the updates. So that's why we have the permanent link. So if Shane is my GP, I can permanently put in contact the GP with the source of all the information. And this is another point, because all the information relates with the healthcare professionals or single organization or region. So we need to understand how to manage also the provenance of each information that conveys into the EHR. Do we want to call it EHR, a bunch of documents that compose our medical history, our list of medication? We can call it as we want. This is our patient, our knowledge as a patient, and we need to support this also, of course, for the next future.
Yeah. And by complying to the EHRF and EHR systems, will deliver structured data, but will systems actually deliver all of the data in a structured way?
That's a tough question. 25 years ago, developing our, almost 30 years ago, developing our first version of EHR system, we had more or less 200 structure fields for a physical examination. Nobody compiled it correctly. So that's why we somehow reversed the process, considering what is called currently narrative medicine. So the narrative text somehow contains more useful information for the healthcare professional than reading 200 structured data elements. So we need to understand that the brain of the physician is built with that kind of knowledge, that kind of approach, discursive approach, not structured approach. And we need to connect this kind of approach with the needs of IT systems and everything that stands behind the usage of information for research or whatever, with this kind of balance of, okay, I need to collect some unstructured information because I cannot present 2,000 structured elements to a physician just because I want a yes and no for all of that. And I need to support automatic data processing somehow and research. So this is a really delicate balance. We experimented a lot of different solutions, but eventually the only solution that is currently really, let me say, supported and used is not the full text, but with the minimum amount of text, of structured information required. And this is the minimal core data sets of structured information that is currently not recognized anywhere, because each healthcare settings, each organization needs to define what might be the core business or the core elements on wider data sets that needs to be collected mandatory on EHR system, basically. So this is a tough question, and nobody, believe, has the right answer that can be applied to all the healthcare providers.
So actually, as AI is already pretty well employed in structuring and coding, whatever, without talking about anything to do with decision making on clinical, do you think AI could actually help with the process of structuring the data?
Well,
yes.
That's another really good question, because we were experimenting the application of AI in the last year, essentially talking about not only machine learning models, so more, let me say, algorithmic, more deterministic, and foundation model, large language model, that are not so really deterministic. If you ask to a large language model twice the same question, we respond likely with two different answers. We need something deterministic, clever, smart, applied by LLMs or foundation models that is hopefully something that we can certify as a medical device. Because we need to reach that point where structured information and unstructured information lives together in the same world, but we can use one or the other according to our needs. Many times patient needs is to read something, data provision, or I don't know, medicinal provision needs the other part, needs the structured thing, because need to manage, I don't know, a warehouse. But in between there is nothing that right now can ensure us that we are providing high quality data and we are not hampering the whole process in any phase that we are inserting an AI model or LLM.
Mm. If I may,
yes,
Stefano, I
please.
know at least two Finnish startups that do LLM-based automatic coding, and they are not using generic LLM models like ChatGPT or Claude or something like that, because those are the ones that tend to variate with the answers, but AI can be used in different ways. So that
I didn't specify that, of course, due to, let me say, privacy question. You cannot use, you can use the open weight models in ChatGPT, the zero-shot model, and you need to refine it, and you can rag it, so you need to add something around that can somehow perfection or improve the performance. But of course, this is again a matter of we don't know how to test extensively the results for, 5 million people at least. So we are talking about basically the same things that we are currently applying at phase 1 of new drug. So we need to test the AI model as a new drug. We need to test it in several layers, extending the population, extending the basis for also improvements, because we can do that in AI models.
Just one quick last question before we wind up. So, Michael, have you got any thoughts about how startups or young entrepreneurs in IT are thinking about EHDS? Are they feeling like it's going to be fantastic for them, or it's a bit of a mind bender at the moment?
Well, from my perspective, startups are really willing to adopt EHDS, and it's really easy for them.
Yeah.
Compared to legacy EHR systems that we've been building their systems since the 90s, and nobody's able to touch the system without breaking 12 different things. However, if I'm starting something from scratch today, I can just point my Claude to EHDS regulations. Hey, code me something that's compliant with that. I'm done. So there's much less resistance.
It's a positive era, really.
Yeah.
And for citizen readiness, did you have any experience of citizens using the yellow button that, and how that worked out, Stefano?
Currently, yellow button is under, let me say, experimental usage on a limited cohorts of patients, because we currently don't know the extent of, let me say, the legal boundaries of, okay, you need to inform the patient that they are downloaded something that needs to be maintained somehow, so I cannot send playing files to whatever using we don't know what. So this is something that is currently addressed by XShare to understand also the scaling up of the model, because we are just testing in a few countries what is the technicalities that we need to adopt for a scaling up. We are relying on some EHDS article for that, but we really need to understand what is the real chances for the XShare button to succeed also in the next future, talking about the extension at European level for all the countries.
Okay.